the one area that a lot of people may have heard of mast cells is in the area of allergy. Mast cells are also involved in allergy because allergy, like allergens, like pollen and nuts and lots of things that people are potentially allergic to, are things that the mast cells will recognize as bad, and again, releases histamine and causes a
Right.
downstream effect. But mast cell activation syndrome doesn't necessarily mean that you have an allergy, but you could have an allergy or allergic responses. And that's
Right.
what makes the syndrome a little bit complicated. So everybody has mast cells. Everybody's mast cells will, um, they'll fight whatever they
Yeah.
come in contact with. You know, the example I like to give is COVID. Okay, so
Yep.
it's just because a lot of people
I
have,
give that example all the time.
right?
Yeah.
It's
Go ahead.
unfortunate, to be honest, really
Yeah.
unfortunate we have to use this example, but you know, a lot of people know people or themselves who have had COVID.
Welcome to Demystifying PANS and PANDAS, the podcast where we uncover the mysteries, breakthroughs, and hope behind these life-altering conditions. I'm Dr. Nancy O'Hara, a board-certified pediatrician, educator, and advocate with over 3 decades of experience helping children and families navigate the challenges of neurodevelopmental and neuropsychiatric conditions, especially PANS and PANDAS. These disorders can feel overwhelming, but here we'll break down the science, explore transformative treatments, and share stories of resilience and recovery. If you've ever wondered what's possible for your child or how to find answers, this is the place to start. Let's dive in.
Hi, everybody. Dr. Nancy O'Hara, and I am thrilled to welcome Tania Dempsey to the podcast on Demystifying PANS and PANDAS. Tania is an expert in mast cell mediated disorders, mast cell activation, has taught me so much in that field, and I'm just thrilled to have her with us today. So Tania, thanks for joining us.
Oh, thanks for having me, Nancy. I'm always happy to talk about all things mast cells.
Well, it's so important and so
Yeah,
misunderstood. But first,
exactly.
just tell our listeners or viewers a little bit about how you got to this part of your career or life.
Yeah, well, you know, it's been an interesting journey, as many of us have had, you know. Um, when I started, you know, I come from a very traditional background, and, you know, was doing internal medicine and, you know, conventional practice for a number of years before I realized, you know, this is really not working. I need to have time to speak with patients. I recognized early on that we were missing things when we were dealing with our patients, that 5 minutes is not enough. You need to dig, you need to get a history. So I was always sort of thinking about, you know, root cause medicine before I even understood what root cause medicine was. And so, you know, eventually that sort of made my way into integrative medicine. And then once you're in integrative medicine and you have time to talk to patients, to think about the cases, to research, right? Inevitably, you're going to learn a lot, right? And I learn something every day from my patients. And I have one patient in particular who I think really taught me about mast cell activation syndrome. And she's the one who really, um, you know, got me sort of launched me into this world because she had, this was probably back in 2015, she had, you know, this very complex multi-system inflammatory symptoms that I just could not put together. You know, there were missing pieces that I just didn't understand. And I
Yeah.
was determined to figure it out. And one day on PubMed, I came across this disorder called mast cell activation syndrome. And and I was sort of thinking, you know, there are some features that she has that kind of sound like this, but like, what are the chances she has this? I've never heard of it before. I mentioned it to her, and it just so happened that she had a family member who was at the NIH, and she mentioned it to him that I had mentioned this disease, and then he said, "Oh, well, you know, the expert in this disease is Dr. Larry Afrin." And
Yeah.
she said, "Would you mind talking to him?" And I said, I'll try. He was at an academic center. My impression of people in academia was like, all right, they're really going to talk to me. I'm in private practice. And I called his practice, and I spoke to his assistant and I said, I have a case I want to discuss. And he said, they said, yeah, yeah, no problem. You want to talk next week? And they set up an appointment. And I was thinking, who is this guy who's taking this call from a random person to talk about this? He spent at least an hour, if not longer, probably an hour and a half, just giving me a brain dump on mast cell activation
Wow.
syndrome, right? And after that, I mean, I was sort of hooked and I was sort of thinking, I think this is the answer to so many things that I was seeing that I couldn't understand, right?
Yes.
And then eventually, he came and joined my practice, because we had kept in contact. He saw the work that I wanted to do and the center that I wanted to create. He was done with academia and I'm like, all right, let's do it together. And so he's in my practice now. We learn, we research. And, the goal is really to continue to try to figure out how to get patients better. I mean, that's the
Yeah.
bottom line,
Yeah. For all of us. And,
Yeah.
although, mine took me in a slightly different path, there's so many similarities. I mean, really wanting to listen to the patients and spend more time and figure this out, be the detective. And you do that so well in your patients. So, but I think, on this podcast, we have hopefully a lot of parents, but we also have some practitioners. But there may be a lot of people who really don't understand what mast cell are. So can you start there for us? Do you mind?
Yeah, yeah, absolutely. And actually, even before I say that, I'll
Okay.
do that. I think it's just important to know that while I, am focusing on mast cell activation syndrome in a lot of patients, I treat the whole patient. So a
Right.
lot of these patients have other things that are either making this condition worse or this condition is making that condition worse, right? So I treat Lyme and mold and PANS and PANDAS and all those things too, because they're all interconnected.
Right.
And
Absolutely.
I see it through the lens of a lot of these things through the lens of the immune system.
Yeah.
And so the mast cells are they're a cell in the immune system. They're part of the primitive immune system. We call it the innate immune system. And so they're our first line of defense against our environment. And so, they're the ones that are sort of sitting in our bodies and watching for invaders, whether they're viruses, bacteria, fungi, whether it's toxins in the air, wildfires, right? Smoke, whether it's plastics, so whatever toxin or foreign substance is there coming in contact with our body, the mast cells are ready to attack. One
Yeah.
of the ways they attack is they make granules um, of mediators, chemicals. A chemical that some listeners may have heard of is histamine, is one of the many, many mediators that mast cells make. Actually, mast cells make over 1,200 different mediators. And some mast cells don't make histamine at all. But since people know about histamine, um, the mast cells will make these granules of these different chemicals. It sees the thing that it needs to fight. It explodes, it degranulates, releases those chemicals, and the goal is for those chemicals to kill, right, and damage whatever that foreign
Right.
substance is or infection. But the problem is that when the mast cells explode and release these chemicals, it's not only affecting that foreign body, that infection or whatever else. It's in our tissues,
Right.
and it's causing local and systemic inflammation. Those chemicals are also not great for our own cells and tissue. Mast cells are in every organ in the body. They're white blood cells, but they're not in the bloodstream like a lot of other white
Right.
blood cells. They're in all the areas of the body that are in contact with the environment. So they're in the skin, tons of mast cells in the skin, the respiratory tract, the GI tract, the nervous system, lots in
Yeah.
the nervous system. which kind of will bring us to the PANS and PANDAS discussion.
Right.
Tons in the brain. And again, they're there, ready to fight. They have other ways of fighting. They talk to other parts of the immune system. They send signals for certain cells to make antibodies to fight in that way, right? So there's lots of things going on. It's very, very complicated. The one area that a lot of people may have heard of mast cells is in the area of allergy. Mast cells are also involved in allergy because allergy, like allergens, like pollen and nuts and lots of things that people are potentially allergic to, are things that the mast cells will recognize as bad, and again, releases histamine and causes a
Right.
downstream effect. But mast cell activation syndrome doesn't necessarily mean that you have an allergy, but you could have an allergy or allergic responses. And that's
Right.
what makes the syndrome a little bit complicated. So everybody has mast cells. Everybody's mast cells will, um, they'll fight whatever they
Yeah.
come in contact with. You know, the example I like to give is COVID. Okay, so
Yep.
it's just because a lot of people
I
have,
give that example all the time.
right?
Yeah,
It's
go ahead.
unfortunate, to be honest, really
Yeah.
unfortunate we have to use this example, but you know, a lot of people know people or themselves who have had COVID. And we know that COVID is this type of virus that activates the immune system, particularly mast cells, but other white blood cells as well, right? There's this cytokine storm that everybody sort of talks about. But there's a subset of people who get COVID, their immune system kicks in, they deal with the virus, and then everything sort of like resets. I like to think of
Yep.
it as like the immune system just goes, okay, we're done. And their body goes back and is sort of, you know, fine, right? So we know people who have had COVID and have had no sequelae after it, right?
Right.
They're fine. Then there are people who have had COVID where the immune system does not reset. The
Yep.
immune system continues to be activated. And there are lots of reasons that could be. We don't have to go into that part, or we could, but there could be residual spike protein. There could be residual virus. I mean, there are a lot of theories on this.
Right.
Nonetheless, the mast cells and other immune cells continue to be activated and continue to cause a problem, and that's mast cell activation syndrome.
Yep.
Because again, everybody has mast cells that activate, but if they reset, those people do not have mast cell activation syndrome. The
Right.
syndrome is that even at baseline, there's always a little bit of activity happening, there's always a little bit of inflammation, and then there's a big event like COVID that takes them over the edge, or they get exposed to mold, or they get Lyme disease,
Yep.
or they get exposure to some kind of trauma,
Yep.
stress. I mean, there's like the list is, you know, is very, very
Right.
long. It then takes them into this area where the mast cells can't stop and they
Right.
continue to fight
Right.
inappropriately.
And we see that all the time. And trauma, but for us and their kids, the mold, the vector-borne diseases, COVID, certainly this mast cell activation syndrome is what we see. And I think it's fascinating. You said so many things.
Sorry.
It's wonderful. But I think number one, it's not just histamine. 1,200 different mediators that are
Yes.
released when the mast cells degranulate, and people need to realize that this isn't such a simple, I want to get a histamine level to see if they have mast cell activation syndrome. I hear that all the time. And
Right.
so we'll get into that, but
Yeah.
so
Yeah.
many facets of that. And then two, that although they can have allergic symptoms, they don't have to, that there are mast cells
Exactly.
in all the parts of the body and the brain. A lot of our kids, it's, it may just be anxiety and brain fog, and they don't have a thing on their skin, and it's still mast cell activation syndrome.
Exactly, exactly.
Yeah.
And I think what's really, really important to understand is that this is a multi-system inflammatory
Right.
disorder, okay? But there could be systems or a system that is more vulnerable in a particular patient. And so for
Right.
some patients, the neuropsychiatric manifestations are much worse
Right.
than any other problem in the body. Although they might have some mild GI symptoms, they might have some joint pain, they might have headache, like they may have other systems involved, but they can just have this predominant anxiety, OCD,
Right.
depression, or whatever. And that's the problem, is a lot of those patients, when the neuropsychiatric symptoms are the most predominant, they get shipped off to the psychiatrist
Yeah. Yeah.
without understanding that there's a medical reason
Right.
for that.
Right. Right. And never treating or even looking at the immune system and this particular piece of it too. Yeah. The other thing that I find fascinating is you have like a family living in mold, and you have several people that may be susceptible, but one has neuropsychiatric symptoms, another has respiratory symptoms, another has more classic symptoms, but the baseline root cause, the mold activating the mast cells, is the same, but they're presenting very differently.
Mhm. Yeah,
Yeah.
exactly.
And historically, I mean, mast cells helped us to deal with toxins, with parasites. But I think
Yeah,
one of the reasons it's so much more prevalent is we live in such a toxic world. You know, the plastics and all of that
for
that are
sure.
in our world that kick it up. And now we're getting a backfiring, so to speak, of that protection.
Oh, 100%. And I think that we're going to continue to see an increase in this condition. You know, the in 2017, I think it was 2017, the paper came out of Germany where they estimated like 17% of the population of Germany had a mast cell disorder like mast cell activation syndrome. 17% is a fairly large number. That was already, 7, 8 years ago. And by my estimates and talking to colleagues, I think we're definitely closer to 20%, if not more. And when you look at how many people are suffering from, let's say, long COVID,
Right.
you'll see how those numbers are actually quite similar. About 20% of people probably at this point have some features of long COVID or post-COVID. And I think that sort of makes sense because that's about what we're seeing with mast cell activation syndrome. And I think it's going to get worse the more exposure and toxins and the like are, that we're exposed to. I think it's inevitable, which is sad.
Right. I agree.
Yeah.
So you have a patient where you're suspecting this from history. Do you always do testing? And if you do, or when you do, what do you do?
Yeah. So, because I like to publish and because I work with Dr. Afrin, we do try to do as much testing as possible to determine the diagnosis, because then first off, the patient has the diagnosis, which then really validates them and
Right.
allows other doctors to recognize that they have a true disorder. So I think it's so important to get the answers for the patient to prove that that's what they have. It also does help, when we do research and we publish and things like that. But most importantly, it's always the patient. So I do try to test if I have a suspicion. We try to do the testing. Now, there are there are issues that come up. The testing may be negative. Maybe we have to do a second round of testing. Some of the testing can be costly, so then we have to, sometimes
Yeah.
maybe make some concessions and try to figure out how to get the most bang for our buck, when doing it. But generally, if I can, what I want to do is I want to do some blood work on the patient, and I do want to measure histamine. I want to measure a plasma histamine. I can measure a whole blood histamine because there's a chance that the histamine will be picked up, and
Right.
and and that again is a helpful marker. Then, we also test for another marker called chromogranin A. Chromogranin A can be produced by mast cells. Unfortunately, it's not specific for mast cells
Right.
because there are other cells that make it. The same with histamine. There are other cells that produce histamine. So they're not specific markers, but if you have enough of them, it kind of supports that we're dealing with this particular disorder. And in the blood, we can also check tryptase, which is another potential marker. There are some downsides and some issues with tryptase. And then heparin is a very sensitive and specific marker of mast cell activation syndrome because mast cells are the only cell in the body that actually makes heparin. Heparin is a blood thinner. Some people may
Yeah.
have heard of it because they give it in the hospital if you have a blood clot. But it turns out that mast cells are the cell that
Mm.
manufactures minuscule amounts when they're activated. And if you can find the right lab to do the right assay, and which we're very fortunate to have, you can detect those minuscule amounts of heparin, and that can help with the diagnosis. Because if someone has an elevated heparin, there's nothing else that causes an elevated heparin but mast cell activation syndrome. So it's a very specific,
Fascinating.
finding.
Yeah.
Ideally, I'd like to get two markers or points of laboratory evidence to support the diagnosis of mast cell activation syndrome. But if you have a heparin level, it's pretty convincing, and then you sort of see if you can get something else. So that's primarily the blood work. There are other markers that I will look at because I think it's helpful, but those are, the primary ones. And then we do urine testing, which is random urine and 24-hour urine to look at the metabolites of
Right.
some of these mediators that mast cells produce. The problem with those mediators is that they are very thermolabile, and including the ones we do in the blood too. Very thermolabile, meaning that they're very heat sensitive
Yep.
and they get destroyed very quickly. So when patients do this test, they have to control the temperature. They have to be sure that the urine is kept cold at all times. They have to make sure that it's brought to the lab cold, that the lab keeps it cold once it gets there, doesn't leave it on the counter, which we've
Yep.
seen. I've had patients who have done this test, let's say locally at their like local LabCorp or whatever, and they will say, I gave it to the lab tech and she just left it sitting on the counter. I have a feeling the results will be negative, and sure enough, they're negative. So every step of the way has to be controlled in order to detect those various mediators. And we can
Yeah.
measure things like prostaglandin, D2, we can measure leukotrienes, metabolites of histamine. So there are a bunch of
Right.
them. Um, and then one other way that works for a lot of my patients, especially adult patients, harder in kids, if they've had an endoscopy or
Mm-hmm.
colonoscopy, often there are biopsies. Kids who have, let's say, eosinophilic esophagitis, or they have swallowing issues or whatever, sometimes they'll go down and they'll scope them, right? And they'll take biopsies. Um, you can request the biopsies to be stained with a special stain called the CD117 stain, and that actually looks for mast cells in the biopsy sample. They don't routinely look for mast cells. That's the problem.
Right.
So the results often of these biopsies is normal. And then, we, send it to our pathologists, or there are various pathologists all over the country that are willing to redo the staining on these samples. And if you have more than 20 mast cells in the what's called a high-powered field,
Right.
that's a very, very, a sort of suspicious finding for mast cell activation syndrome, and in line with the criteria we use for diagnosis.
Yeah. Now, obviously, they're having an endoscopy for other reasons, so they have some amount of GI symptoms.
Correct.
But would you see that in someone who does not have GI symptoms? In someone who has another system that is very affected by mast cells? Has that ever been
It's a
looked
great
at?
question. It has not been published, but I
Okay.
will tell you anecdotally that I have a patient who has more of the respiratory skin and brain stuff, brain
Yeah.
fog primarily, with almost no GI symptoms. And she had a routine colonoscopy. And or she was going for routine colonoscopy. And I asked the GI doctor, look, if everything is clean, what they'll do when they do a colonoscopy is, unless there's a polyp, if it all looks normal, they won't biopsy in
Right.
like a
Right.
routine over 50, patient. I asked them to take biopsies, which they kind of weren't thrilled with, but I said, look, I just, because I really want to make the diagnosis, and we were sort of on the fence still with a diagnosis, but she definitely had a multi-system inflammatory disorder. Um, and the biopsies were positive in the colon. She had no GI
Wow.
symptoms.
Yeah. Yeah. So it makes you think that in a lot of these people, even if the brain is their main area of neuroinflammation or the skin, that they may well have overactivation of these mast cells in other areas, but
Correct.
for other reasons, they're not showing the signs and symptoms.
Correct.
Fascinating. You'll have to let me know when that's published. So,
Yeah, I gotta work
but
on that.
one of the things I heard you say also is colic. When we're talking about kids, colic can actually be a sign of mast cell activation.
Yeah. Yeah.
So GI
Absolutely.
symptoms. Yeah,
Yeah, absolutely. And I think that these are the kids, when we take a history, my patients are a little older, right? They're, adolescents or older. But when you take that history and they say, and we ask them, how were you when you were an infant? Did you have colic? Did you have any issues, right? If they had early colic, it's a very again, suspicious symptom that makes me think that they had some evidence of mast cell activation syndrome early in life
yeah,
that was, relatively manageable, right? And
yeah,
they can go through the early years with, a little bit of this and a little bit of that, a little bit of colic, a little bit of an ear infection, a little bit of, these somewhat, normal, quote unquote, normal
yeah,
childhood things. And then at some point in their either early childhood life or later childhood life, there's, a bigger event that then brings it out.
yeah. Some kind of trigger, as we're seeing
Yeah,
so much with COVID,
correct.
reactivating so much of underlying root causes. Yeah. So how, maybe describe just a little bit more, because this is a PANDAS
Yeah.
podcast, how the
Yeah.
mast cells impact the neuroinflammation
Yeah.
specifically.
So the way I think about it is that the nervous system, the brain, um, has various cells that are involved in keeping the brain healthy. You have the neurons that are sending the signals in the electrical signals in the
Right.
brain and elsewhere in the body. We know that all neurons are surrounded by mast cells. So I like to draw for my patients, and I'll draw like, here's a neuron, and then I draw these little things around the neuron, and here's the mast cells. And
Yeah.
so if you just look at the neuron itself, you'll see that if the mast cell, and it's a two-way street, so the mast cells, if they get activated, they see something not right, and they start to release these mediators. They'll send the signal to the neuron, and that causes a little inflammation at the level of the neuron. The neuron then releases a neurotransmitter to tell the mast cell, something, and then the mast cell has to release more mediators, and then it sets up this really vicious cycle. So at
Yeah.
that level, it's almost like this. I think about it as if you think of a neuron like a wire, and you have the insulation around that wire, and it just starts to get frayed over
Yeah.
time, right? So then the signals are not being transmitted correctly, right? There's like short circuiting that happens,
Yeah.
okay? Now, if that's happening in the brain, right, you can imagine that the signals now are going to be affected, the neurotransmitters are going to be affected, and that's going to cause various, whether it's brain fog, whether it's OCD, whether it's extreme anxiety or depression or paranoia or psychosis or, right? I mean, there's so many
Right.
manifestations, right? But also, there are other cells in the brain that are also immune cells. There are astrocytes and microglia, and they're responsible to, sort of also protect, like mast cells. They release their own set of mediators and chemicals to sort of control what they're seeing going on in the
Right.
brain. And they talk to the mast cells, and the mast cells talk to them. And so there's this really great paper that has a great picture or an image of all the arrows going from, it starts with some kind of infection. They in this picture, it's like a virus, a bacteria or something. And then you have the arrows on how it's affecting the microglia, the astrocytes, the neurons, the mast cells, and everything is going, in different
Yep.
directions and setting up this perfect storm of inflammation, and it's just going, in a loop. And so and hard to stop it, right? So that's how
Right.
I think about PANS, PANDAS, autoimmune encephalopathy, neuropsychiatric, inflammatory neuropsychiatric disorders, is that there's this loop. The mast cells are involved, whether they are the primary
Right.
trigger of all this, or whether they're just, kind of playing along with the other immune cells and other cells in the body. We don't know, right? Chicken or the egg, but
Right.
probably a little bit of both. And the key that I have found in my practice is that yes, you have to deal with the trigger. If the trigger's an infection or mold or whatever it is, you've got to eliminate, like the first step in treating mast cell activation syndrome is eliminating triggers.
Right.
But if you could also figure out a way to stop and minimize the amount of mediators that the mast cells are releasing, stabilizing the mast cell so that it's not as reactive, then that helps all these other processes
Right.
kind of calm down.
Yep. Yep.
And it's pretty miraculous when it works. When you get it and you find the thing that's going to shut down the mast cell, and you see the neuroinflammation disappear. Like I have this one case that was like just mind-blowing with just an antihistamine. Sometimes it's
Yeah.
as simple as that. It's like like the inflammation just goes away and the
Yeah.
brain comes out.
And so addressing this mast cell activation syndrome can decrease the neuroinflammation
Correct.
and then decrease the symptoms. And
Yeah.
rather than the SSRI to address the anxiety or, OCD or
Right.
whatever, or maybe in addition to it,
Correct.
addressing this can really make.
Correct.
So what do you use? What strategies to address mast cell activation syndrome? You
Yeah.
mentioned antihistamines. I mean, simple over-the-counter antihistamines.
Yeah, yeah. Again, step one is eliminating triggers. So you're
Right.
always going back to the history with the patient and trying to determine, is there something that is within their control that they can eliminate?
Right.
Sometimes it's not in their control. Okay. If they have Bartonella, right, that's not in their control, but we're going to help them deal with that. But if there is, so let's say someone in the home is using scented products or cleaning products, or there's a gas stove in the home that may be triggering somebody, right? There are all these things that you don't even think about, and some of those are controllable or fixable or
Right.
so you always do that first. And while you're trying to figure that out, yeah, then you go for the treatments. And I think that the easiest are the antihistamines. Now, antihistamines there are pharmacologic antihistamines, and then there are nutraceutical, antihistamines, right?
Right.
So, it really depends on the patient. So it could be there are a number of over-the-counter H1 blockers. Those are the antihistamines that block the histamine 1 receptor.
Yep.
Claritin or loratadine, Zyrtec or cetirizine, levocetirizine, which is Xyzal, and then Allegra, which is fexofenadine, and Benadryl, which is diphenhydramine. And so you have the brands, you have the generics, and you have all this stuff that you can try over the counter. Liquid pills, sometimes you got to try, a variety of them. And sometimes when you find, one that works, it's great. Sometimes we have to move on, and there are a number of prescription H1 blockers. There are also some H1 blockers that we have to get from overseas that we don't have available in the US. But I do recommend that patients work to try to figure out if there's an H1 blocker that is particularly helpful for them, even if it doesn't eliminate all their symptoms.
Right.
And I think that's an important point because I think sometimes the patients are looking for that one intervention that's going to help everything, right? So
Right.
sometimes they take an H1 blocker and it helps, I don't know, we'll take a symptom like it helps their headaches,
Right.
but didn't help their anxiety and it didn't help their itching or whatever the other symptom is, right? And that's okay. If you get something that works on one symptom, it means that the mast cells in that area are responding to that, but the mast cells in a different area have different mediators, have a different way of responding. So you have to keep sort of working through. So there are patients who need multiple H1 blockers to try to achieve that, or their histamine is not an issue for them at all. And there are
Right.
definitely patients where antihistamines are just not going to do anything, and so it's not even worth having them on that. There are H2 blockers that block the other type of histamine receptor. Those histamine receptors tend to be primarily GI, but
Right.
I have patients who take these H2 blockers who don't have GI symptoms, who get, relief of other systemic symptoms that are not GI, right? So
Right. Right.
so it's always worth trying. So one of them is famotidine or Pepcid. Tagamet is another one. And Zantac was one that was ranitidine was one that a lot of people did well with, but it was pulled from the market. It's very hard to get right now. But I heard it's coming back, so we'll see.
Okay.
Um, and then, there are a number of nutraceuticals that I turned to early. These are like the early days of like we're trying to just figure out and deal with what we'll call the low-hanging fruit, things that are sort of
Right.
easy. Vitamin C is a natural antihistamine. Quercetin is a mast cell stabilizer with some antihistamine properties. Luteolin is another very interesting compound with these sort of mast cell stabilizing properties. And there are others, but those are other ones that, also kind of easy to try. They work in some cases, they don't work in others. Sometimes they cause side effects in others, right? So the challenge is really like to be very vigilant about what it's doing, knowing when to move on. And then, again, sometimes we have to move on to the more, I don't want to say aggressive, but, a little bit
Right.
more involved treatments.
Right. And do you give each a period of time? I mean, are you saying to your parents, hey, let's try this, or patients, let's try this one for X amount of time? I mean, one of the things I think so much of the time we're looking for the magic bullet. We're looking for that one thing. And part of what you're saying is something that I learned very early on. If they've tried one antihistamine, they've tried one antihistamine. They, that's it. It may be that a different antihistamine would work or a different nutraceutical. Like, are you talking about all of that with your patients? I find that to be a difficult piece of this.
It's no, it's very difficult. And I think that, yes, I think a lot of people just sort of feel like, okay, I tried the Claritin and it didn't do anything. So I must not have a mast cell problem because
Right.
it didn't do anything. So that's also difficult, right? So what I say to people is that the mast cells are, they're fickle. We don't know. We don't have the research yet. It's coming. But we know that the mast cells have these mutations. They're called somatic mutations, and And everyone's mast cells have anyone who has mast cell activation syndrome will have different mutations. Those mutations dictate which mediators the mast cells, which of those 1,200 mediators are making.
Yeah.
Eventually, we'll be able to do a test where we test your mast cell and we know exactly what mutation it is and what your mast cells are making, and then we can target, the treatment to it. I don't think we're that far away from doing that, and there are a few labs that
Interesting.
are studying that. But until we get to that, right now we have no idea, other than, yes, we've done these mediator tests, and maybe we know that the patient makes leukotrienes. So we sometimes, will try to go after that. But other than that, it's difficult. So it's trial and error. And I say, look, typically, first of all, you're going to know pretty quickly if you don't react well to it. Usually
Right.
within a few doses, it's going to be clear this is either not the right drug, or the drug has an excipient, which we should talk about, has something in it.
That was on my list. Yep.
Okay, we'll talk about that. Something in it that the person's reacting to. So then you have to move on. But let's say there's no bad reaction, but you're not sure if it's working or not yet. I say 2 to 4 weeks
Yeah.
is about the time. Sometimes I move it quicker, especially if the patients and parents are, really observant and they feel like they really have a good feel for it. Sometimes we can move it along, but at least 2 weeks to really know what it's doing. If it's not doing anything, then we move on. And so again, we're trialing. I really tell my patients that ideally I would like to run through every antihistamine over the counter. If we can, 2 week trials, 2 to 4 week trials, depending. And then many of them will, at the end of all that, and what, even if they had a good response, even after 2 weeks, they're like, yeah, I actually think this is helping. I still tell them to move on, because then because the next one could be even better. But then once
Interesting.
they've done all of it, then they can look back and say, oh, you know what? Xyzal was the one that actually I did have the best response to. Okay, so then go back to that. Now let's do that for longer. Let's keep that on board and then figure out what else we add on. So I do think,
Fascinating. That's one thing I have never done is tried all of them. I find that if I find one that's working, I'm like, stick with it. But that's
yeah,
very interesting because it may help other symptoms because they're all so different, even though they're all
correct.
H1 blockers. That's a fascinating piece. Great tidbit.
Yeah,
And
yeah,
also I don't want to cut you off, but you did mention excipients,
yeah,
and
yeah.
that is something else that you reminded me of not too long ago that I think is so vital for people to understand. Do you want to talk about that a little bit?
Absolutely. All drugs and supplements contain other ingredients mixed with it. Okay, and there are a number of reasons why they do that. It could be to fill the capsule up. It could be to keep the tablet together. I mean, there's all kinds of. I'm not in the pharmaceutical industry, but I understand that there's a need for some of it. There's also what I don't understand is why pharmaceuticals contain dyes.
Oh,
I don't
I
know
know.
why a pill has to be pink, or the liquid has to be pink, or has red. Don't get me started on that.
I know.
That's infuriating. And I will tell you, it's not like that in other countries. We're
Yeah,
probably the worst with this, but the dyes can be a problem. The other ingredients can be a problem. Again, mast cells are really sensitive to these different chemicals. So sometimes the drug is perfectly fine, but the drug is mixed with a dye or another filler, and the person is actually reacting to the one of those things. And
yeah,
then they're dismissing the drug altogether, thinking that they have either an allergy or a reaction to the drug. And then, we've taken that class of drugs off the table, but yet it may be that there is something mixed with it. And the same with supplements.
right.
I would say the most common offenders are definitely the dyes in the pharmaceutical world. I would say methyl cellulose, or any kind of cellulose, tends to be problematic.
Hmm.
Cellulose is a plant
Yeah,
derivative. Now, what I understand is that cellulose can come from different plants. Can come from cottonseed plant, it can come from birch trees, it can come from, like, there's a list.
Yes.
I can't tell you how many, off the top of my head, but like lots of different trees and plants, um, they can derive the cellulose from. And a lot of times, either the pharmacies or the pharmaceutical companies, they don't even know where
Yeah.
their cellulose is coming from. So I have patients that have figured out that cellulose from whatever tree is fine, but cellulose from another is not. But for the most part, it's very difficult
Wow.
to figure that out. So very often cellulose becomes a problem, because there's some kind of, again, it's a very um, triggering for mast cells. Not everybody,
Right.
but it does seem like that's a common offender. And there are a number of others. Povidone is one I see sometimes, titanium sometimes, magnesium stearate sometimes. So, if patients know that they are, or parents are seeing that they're reacting, that the kid is reacting or they're reacting to something, it pays to look at the ingredient list,
Yeah.
which you can find online. It's not always super accurate, but for the most part, you can get at least like the broad strokes
Yeah.
on it. And what you can do is, if you start to see that you're reacting to a number of drugs, you start to see what things they have in common.
Yeah.
And very
Yeah.
often there's like a standout. Like, oh, these drugs all have this ingredient. Then what you can do is then you can work on compounding it.
Right.
So if cellulose is a problem, then you use gelatin capsules and you
Yeah.
use a rice flour filler. So you find ways to get around, because the problem is that even compounded drugs often they'll use a cellulose veggie cap,
Yep.
and they'll use cellulose filler.
Yep.
And that's just sort of standard. So the excipient problem is very involved. I don't want to make it more than it is, but it is something to think about, especially when you have patients who are reacting to a lot of things,
Right.
and you can't get them on anything. You have to go back and say, are they really reacting to all these drugs? Or is there
Right.
something else those drugs have in common?
Right. And I think exactly, we don't want to make it sound like it's everybody that comes down the pike and everybody has to
No.
get everything compounded. But for that multiply resistant child or adult that seems like everything they're reacting to, thinking about the other things that are in it. After we talked recently, I had been using, for instance, cromolyn sodium in the little plastic vials. And
Mm.
when I changed it and compounded it, and not into a cellulose containing veggie cap, because I did that the first time. It worked
It worked.
beautifully. And so I
Love
think it's
that.
another little pearl that really can make a difference when, because so many of our patients, or my patients at least, are saying nothing's working, nothing worked from
Right.
anybody else. I'm not trying that again. And I have to say, let's just back up and let's look at why didn't that work, And as you're saying, sometimes it can be the excipients.
Yep.
Sometimes it was just the wrong H1 blocker. Go ahead.
Yes, exactly. But I want to make a point about the plastic, because I think that's really important. So cromolyn is something that is, it's really easy to use, because it's liquid in a vial, especially for kids, right? You
Right.
just squeeze it into some water. But the plastic that the cromolyn comes in is different depending on the company that makes the cromolyn.
Correct. Yeah.
And the plastics, degrade a little bit over time. And there are patients who are really particularly sensitive to one type of plastic or another. I mean, listen, we want to avoid plastics as much as possible. Sometimes it's unavoidable, but I have patients who know that they are sensitive to certain bottles of water, right? So you think, how
Yes.
can they're reacting to a particular brand of water, let's say Poland Springs or something. And like, is it the water or is it the plastic that
Right.
the water is in? So the plastic, thing I learned pretty early on with cromolyn is something that, a lot of people are not thinking about, but can be easily, remedied because you
Yeah.
compound it.
Yeah. So so fascinating. Tania, anything, we're running a little bit long now, and I just thank you so much for all of your wisdom and
Oh, it's a pleasure.
information. Is there anything else you want to leave the families or the practitioners with? Any other pearls or?
Yeah, look, I think you have to keep at this. It is tough. And especially, when the kids are suffering and the families are suffering. But I feel like there is a lot of hope. I
Yeah,
do think that the answers are there, and mast cell activation syndrome, or MCAS, may be a big part of this that will bring the PANS and PANDAS under control. So I really do encourage people to talk to their practitioners about getting tested, um, or trialing, even if they can't get a diagnosis, trialing these
right.
things. Because if this is a piece of the puzzle that hasn't been explored, it could be really profound. And so I guess I just want to leave people with hope. Like, I believe that there's always an answer out there, and we just have to keep fighting for it and finding it.
I so agree. There definitely is hope, and thanks for giving so many families hope, seriously. And I know
Mm,
you're incredibly busy, but how do people find you if they want to?
Sure. So, social media, Instagram, Dr. Tania Dempsey, MD. Facebook is Dr. Tania Dempsey. My website is drtaniadempsey.com, and I have lots of content. I have a podcast called
Yes, you
Mast
do.
Cell Matters. You're going to be on my podcast soon. Um, Mast Cell Matters, where we take some deep dives on mast cell and related conditions. So I'm really, really proud of that. And so again, education is my passion. And so I do put a lot of, video and content out there. So I encourage people to take a look.
Yeah. Well, you're great at it. And there really is
Thank
a
you.
plethora of information out there. So, Tania, thank you. So great to
Thank you,
be with you
Nancy.
today. And thanks for everybody joining us.
That's it for today's episode of Demystifying PANS PANDAS. I hope you're walking away with insights, tools, and hope to help you and your child on this journey. If you found today's conversation valuable, be sure to subscribe so you never miss an episode. Share this podcast with anyone who might need it. It could be the lifeline they're searching for. And if you have a moment, leaving a review helps us reach even more families who deserve answers. Also, for more information, training, and community, check out our website, drohara.com, and join our annual membership. And remember, every step forward, no matter how small, brings us closer to healing and understanding. Until next time, be present, be hopeful, and we look forward to seeing you next time on Demystifying PANS PANDAS.